Lovely. Thank you. So what we're going to do, Leandro and myself are going to speak for the next sort of 45 minutes or so and give a bit of an overview on oral health inequalities. And we were just chatting before we started. And, for some of you, this is very simplistic and very obvious. But I think we were aiming to reach out to the wider membership of the European Association of Dental Public Health to make sure that we cover basic principles and as well as sort of emerging topics. So what we're going to do in the next 45 minutes is sort of canter through the current sort of geopolitical context for health inequalities, look at some basic principles of oral health inequalities and definitions, look at some evidence from across Europe, from across the UK, in England in particular, and from Italy. So Leandro is going to give us some details from Italy. And then we're going to really sort of reflect on where we are, what needs to move forward, and in particular, consider this issue of meaningful community engagement with civil society. So let's sort of set the context firstly, and this quotation was from the Lancet editorial in 2019, which was stating that oral health at that point in 2019 was a tipping point. And as many of us on this webinar know, a lot has happened since 2019 in terms of moving oral health forward. So without going into all the detail, we know at WHO there's been a whole host of very positive, exciting developments that Benoit and his team have moved forwards in terms of moving forwards from the resolution, etc., etc. I should have shown a slide of Dr. Tedros meeting one of our former students, which is a lovely picture. But Dr. Tedros, WHO, oral health is certainly moving forwards in a very, very positive direction. Again, looking at the people online, some of us were very privileged to be in Bangkok last November. And those of you that were not able to be there, there is all the different recordings, etc., available on the WHO website. But, and a huge positive atmosphere, creative, innovative, collaborative sense was very evident in Bangkok. And that direction of travel collectively was very, very strong. Indeed, last year, well, 2024, the European Association of Dental Public Health had a great meeting in Crete, the focus of which was on commercial determinants. And again, several of you were there. Lots of really positive, innovative discussions. Mark Pettigrew, Sharon Friel, Paula Moynihan, and others presented at that meeting. And lots of exciting things being discussed in relation to commercial determinants and oral health. But I suppose the broader picture in terms of public health and global health is still the perennial challenge of how do we reduce inequalities in health. And this statement, image from WHO 2008, social injustice is killing people on a grand scale, that is as relevant now as it was in 2008. And I suppose, without being disrespectful, the elephant in the room is the changing geopolitical environment in which we are all facing daily news updates on. So the new administration that's only been in Washington for literally about 6 or 7 weeks, the pace of change has been incredible. And the geopolitical axis is changing. And although, we don't want to analyze things too much already, but the relevance of this for inequalities in health, the relevance of what's happening in terms of the sort of neoliberal agenda from Washington is immense in relation to oral health, in relation to global health, in relation to social justice. And the deregulation agenda, the attack on international organizations, etc., we in Europe have to be super duper clear on what is happening and the threats that are emerging literally on a daily basis. So that backdrop, that geopolitical backdrop, positive in lots of senses, but some incredibly worrying developments in other senses, is all of relevance to what we're all working in our space in public health in relation to oral health. So I just thought very briefly, we should sort of reflect and take stock of the progress of what we've done in terms of developments and the challenges that most definitely remain. Now, this is an old slide from the previous global burden of disease study that was published, 10 years ago, whatever, 5 years ago. The new one just published last week. So now, rather than 3.5 billion people affected by oral conditions globally, I think it's 3.69 billion people affected by oral conditions globally. So the evidence at a global scale and at a European scale is that collectively we still have huge levels of unmet need across our populations. The evidence indicates that we haven't managed to decrease prevalence overall of different oral conditions at a global and regional scale. Enormous burden remains to be tackled. Stefan Lispel and co, of course, have now published lots of data on the economic burdens of oral diseases in terms of both public and private expenditure. And I'm sure all of you have seen the slide. The estimates are astronomical in terms of the costs of oral diseases. And at a European level, we know that in many European countries, out-of-pocket expenditure for oral disease treatments is very high and a major economic drain, especially on those that are economically disadvantaged and marginalized. And again, to set the scene for this particular session is all of us on this call, of course, are aware that our diseases are socially patterned with a very close association with socioeconomic position and our clinical conditions across the board. And we have a mountain of global evidence at European, global level, at national level on these inequalities. So what I'd like to just basically do is, especially for the members of the group that are less familiar with this field, is maybe let's just highlight on what exactly do we mean by health inequalities. And if we go back to Margaret Whitehead and Dahlgren, a classic definition, when we define what health inequalities are, we need to consider health differences that are potentially avoidable as opposed to those that we cannot do anything about. So health differences that are deemed to be potentially avoidable, that are unfair, unjust, and systematically produced in our societies, those are what we would classify as health inequalities. And whether that's dental caries in primary teeth, secondary teeth, tooth loss, oral cancers, severe periodontal disease, etc., all our different clinical conditions in terms of the social patterning fit beautifully into that definition of health inequalities. Oops. So let's now just give a flavor of some of the evidence that's been published either at European level, at national level, to give a sense of the detail around inequalities in oral health. So again, hopefully many of you have seen this European report from the Global Oral Health Status document overall that WHO produced a couple of years ago. So this European report was launched in 2023. And in that report, which is a very useful overarching report, there's various examples of inequalities in different outcomes. So this slide, just looking at caries and permanent teeth by country across the European region. And again, as many of us know, the data strongly indicates that amongst particularly Eastern European countries, the dark purple color, dark blue purple, the levels of caries, and this is for 5-year-olds, is particularly high. So that Eastern European challenge is something that we're very familiar with. This next slide, again, taken from WHO report, looking at levels of edentulism across the different countries. Now, I can't quite see the figures at the very top, but we've got significant variation by national level in terms of levels of edentulism for people aged 60 and over. That variation, lots of reasons for that, partly to do with healthcare systems, partly to do with treatment modalities, but also broader social and commercial determinants that we'll talk about in a minute. This slide on oral cancers, in terms of lip and oral cavity cancers, again, across the European region, is pretty stark. I think almost a 4 or 5-fold difference between the best and the worst in terms of cancer rates, in terms of the mouth. So again, significant national differences by different country. Now, I don't know if Ken Eaton is on the call. I'm not going to share anything on severe periodontal disease. Of course, there's lots of issues about measurement, comparability. The data is not perfect, but the data strongly shows those inequalities by country across our European region. If we now just look in one country in particular, so let's look at England as one example in one country in the UK. We have got pretty good data in England in relation to health inequalities. Previously, Public Health England did some really nice work on this. And this is a map of England looking at caries in 5-year-old children, not the latest survey, 2019, but not that far off. And what we can see, Wales has dropped off, Scotland has dropped off, and Northern Ireland is not there. So this is just England. But across England, we have got these regional variations, significant differences by region in relation to dental caries. Now, I, rather depressingly, have been working for 40 years, and I started my career in the northwest of England, and that map 40 years ago was identical to what it is now in terms of those regional variations. It has not shifted in that 40-year period. So I certainly haven't helped the situation. This next slide is looking at caries experience by index of multiple deprivation. And again, what all of you hopefully are very, very aware of is the social gradient across our conditions. So on the left-hand side of the bar, the most deprived have significantly higher levels of caries on each quintile of the deprivation in terms of index of multiple deprivation. So that stepwise association all the way down to the least deprived just demonstrates in a classic social gradient our conditions are patterned across the entire social hierarchy. This is just looking at it in relation to slope index of inequality across deciles, so breaking it into 10 different subgroups. And again, that consistent stepwise gradient is very apparent. This is for caries, but we could show it for other conditions as well. And even more sort of alarmingly is Public Health England and future and current organisations have been analysing the slope index of inequality for caries for 5-year-old children for the last 15 years. And what this slide shows is essentially since 2008 up until 2022, the slope index of inequality has literally remained pretty static. If anything, it's getting worse in recent years. So despite all the efforts of all of our different collective inputs, in England, we have not managed to really make much of a dent in those inequalities, in this case, in relation to caries in 5-year-old children. Now, just before I hand over to Leandro, who will talk a little bit about the Italian situation, I think it's important also to highlight when we're talking about socioeconomic inequalities in oral health, that we also broaden that out to look at vulnerable population groups that we know have a cliff edge of much higher levels of disease than the mainstream population. And on this slide here, we list a whole range of vulnerable population groups, which there is data of different quality and degree, but consistent data showing that these groups, whether they're people in prison, whether they're people working as sex workers, whether they're people with alcohol, severe alcohol or drug dependence, etc., those subgroups have significant levels of extra higher need than the mainstream population, both in the UK and elsewhere. But let me hand over to Leandro now, who will talk about some of the data from Italy.
Thank you, Richard. Could you hear me well?
Yes, very clear.
Yes, thank you. Perfect. So today I want to address an urgent critical issue, obviously about Italy, that is, as you know very well, that is oral health. And I wanted to specifically highlight the profound inequities that are present with the Italian healthcare system. Next, please, Richard. So the title of this quick presentation is Oral Health, Rethinking the Inequitable and Unfair Italian System. You can move. Thank you. So let's begin by presenting the oral health country profile for Italy that was provided by WHO within the Global Oral Health Status Report, as already was presented by Richard. So as you can see, Italy has a population of approximately 60 million of people. And moving to oral disease, we can see that the prevalence of untreated dental caries is very high, is alarmingly high. And we can see that circa the 36% among children between 1 and 9 years old are presenting untreated caries. And this means that circa 1.8 million of children under the age, in that age range, is affected by untreated caries. Moving to adults, we can see that the percentage is around the 30%, and this means that circa 17 million of Italians are impacted by untreated caries of permanent teeth. Moving on, severe periodontal disease, we can see that Italians affected by periodontal disease are circa the 18% or circa 10 million. And moving to individuals that are affected by edentulism, we can see that circa the 12% or 4 million of adults aged 20 years or more are affected by edentulism. Moving to the risk factors, we can see that in Italy there is a very high availability of sugar, and the per capita availability is around the 87 grams for days. And moving to the economic burden, we can see that Italy spent in 2019 circa 19 billion in direct cost for treating oral disease. And moving to indirect cost, we can see that circa 9.5 billion are spent annually because oral diseases. checking about the public oral health coverage, we can see that is very minimal. In fact, only basic care like early detection and emergency pain relief are available, and comprehensive oral health care coverage and advanced procedures or rehabilitative care are completely, we can say that they are completely absent for the public coverage. You can move to the next slide, please, Richard. So, talking about the Italian public oral health care system, we can see that in Italy there is the Article 32 of the Constitution clearly defines health as a fundamental right. But despite this, oral health remains severely inequitable and significantly underfunded within the Italian National Health Service system. In fact, only between the 5 and 80% of dental care is included in the essential levels of care, leaving about the 90, as you can see from the picture, leaving about the 92% of oral health care to the private sector. To put this in perspective, we can see that in 2019, as said before, households spent circa 19 billion on dental care, while the Italian National Health Service allocated just 85 million. That is circa the 0.07% of the total healthcare budget that is spent in Italy for all of health. You can move to the next slide, Richard, please. Okay. So this profound underfunding obviously has significant consequences. In fact, in Italy, approximately 12% of Italians, that means that circa 5 million of the individuals entirely forgo necessary dental treatments, and nearly the 11% postpone care due to obviously prohibitive cost. These figures not only reflect the economic hardship, but also they are highlighting a worrying public health issue. You can move to the next one, please, Richard. When comparing Italy with other European nations, the disparities are more evident. As you can see from this table, Italy's prevalence of untreated caries in children is significantly surpasses, for example, the one in France or in the UK, because in Italy is, as you can see, 36%. Instead, in France is 29%, and in UK is circa 19%. Moving, for example, on severe periodontal disease, we can see that Italy is we have the 18% of prevalence of severe periodontal disease. Instead, UK is only the 10%, and in France is circa the 16%. Also, the per capita expenditure on dental health care in Italy is the highest because, as you can see, in Italy we spend circa 317 USD, and with most of them obviously are coming from the private spending of the Italian individually. Moreover, Italy lacks critical preventive measures such as taxes on sugar sweetened beverage, and lack also a comprehensive coverage of oral health intervention within public health benefit packages. That these one are practices that are already adopted, for example, by in France and the UK. The absence of these preventive measures contributes directly to increased disease prevalence and a higher overall healthcare expenditure. You can move to the next, Richard. Okay, that's it. Thank you.
Perfect. Thank you, Leandro. I'll put your other slides later on, the recommendations. Lovely, thank you. So what we want to now do is, what we've documented is the problem at European level, at national level, some of the challenges in different countries, the persistence of inequalities. So let's now briefly, because of time, is consider really what are the reasons for these patterns of inequalities, what are the limitations of what we're doing, and what's the way forward. So again, hopefully many of you will have seen different theoretical frameworks for the social determinants of health, and based upon WHO and other seminal documents, these models and frameworks have been modified for oral health. And what we did in 2019 was combine these social and commercial determinants of health to try and put together those structural, intermediate, and proximal determinants linked to the actions in terms of commercial determinants. And, in Crete last year, a lot of discussion around commercial determinants. Another way of sort of presenting this is the NCD Alliance produce a nice sort of summary slide of the same sort of message, really, looking at commercial determinants, which is the obesogenic or cariogenic environments, exposure to marketing of health harming products, industry influence on policies, exposure to marketing, social marketing, et cetera. Now, the important thing with commercial determinants is we know those strategies often are targeted at more vulnerable populations. So those commercial determinants, those drivers from a commercial perspective, often heighten inequalities in health outcomes, including oral health. NCD Alliance also quite nicely looks at what they call health system determinants. And many of us come from a clinical background, working health systems, looking at issues of accessibility, looking at issues about affordability, accessibility of services. That is another driver in relation to these broader patterns of inequalities. But a nice sort of summary statement that Nick Frudenberg from the US stated back in 2015 is the growing evidence about the unequal distribution of wealth and power across race, class, gender produces the differences in living conditions that are the upstream drivers of health inequalities. And I think that brief statement sort of taps in to those combined social and commercial and systems level causes of inequalities. Now, an important point I think we have to constantly revisit, and I've stolen this slide from George Takos in our department, is our tendency within the oral health community and other health communities to focus our lens only on changing health behaviors. And what we all know from the evidence is that there are definite socioeconomic inequalities in a range of oral health related behaviors, whether that's hygiene, tobacco use, sugar consumption, dental services. We know those behaviors are socially patterned. But what we also know from a series of analysis from different parts of the world and different research groups is the health behaviors provide a modest role in explaining oral health inequalities. They are part of the explanation, but a relatively modest overall explanation for those inequalities. So if we only focus on changing health behaviors, we're going to miss the broader inequalities agenda. And, in a sort of visual, simplistic way, essentially what the evidence from WHO and other policy reports are highlighting is we in public health need to be aware of these broader social commercial influences that influence behaviors that then determine patterns of health and disease within our populations. So this notion that social injustice is killing people on a grand scale, it comes back to WHO commercial social determinants approach that highlights the conditions in which people live are the drivers and which explains patterns of inequalities. Now, what I'd like to fairly quickly do is just revisit the evidence on some of the limitations of what our current preventive and treatment modalities are, especially in relation to oral health inequalities. So those of us involved in the Lancet series, other Lancet series on commercial determinants, if we look at the sort of limitations of traditional preventive approaches that have been dominant in both medicine and to a large degree dentistry, is that we've tended to focus on lifestyle, inverted commas, approaches, and on self-regulation of industry, etc. Our preventive approaches have predominantly been individualistic in approach, and the evidence on those individualistic clinical-led interventions is that they're ineffective at reducing inequalities. When they do achieve positive change, which they can and do, often those are only in the short term and they're not sustained in the longer term, largely because there's such limited community engagement and involvement in those policy processes. So that's a sort of broad brush limitations of the sort of clinical behavioral approach to prevention. And a particularly important concept that I would like to sort of stress, particularly for the sort of students on the call, oops, someone just sneezed, is this risk of what we call intervention-generated inequalities. So these are inequalities that have been heightened or worsened because of our professional intervention. And a very nice example, although it's quite old, is a study from Scotland, from Edinburgh, the city where Ivor Chestnut and myself both qualified in dentistry. And this is an evaluation of a Scottish dental health education intervention. And some of you will have seen this slide before, but this slide is showing two positive health outcomes, zero plaque and no bleeding. And you can see on the blue lines are the schools that were determined as non-deprived, so the more affluent schools in Edinburgh. The yellow line is the deprived schools in Edinburgh. And what you can see for both of the outcomes, before the intervention was delivered, there was a bit of a difference in the zero plaque, but in terms of no bleeding, no difference. But what's important to see is the widening of the difference over time. Now, the follow-up is only 4 months. So it's not, it's not a long-term follow-up, but you can see hopefully that the non-deprived schools, they benefited from the intervention, whereas the deprived schools, the yellow lines remained flat, but the difference widened as a consequence of the intervention. Now, that's an old study. You might argue things have changed, things have improved. Well, the more recent study from 2018 from different country, from Germany, different outcomes, looking at dental caries, it showed exactly the same outcome, that the school-based health education intervention increased inequalities in this case, dental caries. So this notion of intervention-generated inequalities is something I think those of us working in public health need to be very conscious of and ensure that when we evaluate our interventions, that we're not contributing and worsening the scenarios. So in summary, what I'd like to suggest is our current preventive approach has not been wholly successful in tackling health inequalities. It's too clinical, it's too narrowly focused, and it's not sufficiently broad in terms of tackling these social and commercial determinants. So let's just finish off by looking at the sort of broader public health agenda, the bolder public health agenda that could be implemented to tackle health inequalities and oral health inequalities. And the first thing I think I would like to really stress is the emerging sort of movement of the desire to reframe oral health as a human right, as a fundamental human right. Not oral health as an individual responsibility or commodity, but as a basic fundamental human right. If oral health is part of general health, which we've argued for many years, that means oral health is a human right for our entire population, which is enshrined in UN Declaration of Rights, WHO Constitution, and national treaties. Now, Leandro has mentioned in Italy, their constitution states health is a human right. The Italian government, however, is not considering oral health within that remit because governments have an obligation, if an issue is a human right, to protect, respect, and fulfill the rights of their populations. If oral health is to be taken seriously, framing it in this human right lens, I think, is fundamentally important. So tackling health inequalities and oral health inequalities needs a multi-pronged approach. Strengthening individuals and families, that could be in a clinical environment, and we'll talk about that in a minute. Strengthening communities and population groups and different measures, again, important. Improving infrastructure, access to services, welfare services, other forms of services are really important. And lastly, making structural changes to the economic, environmental, political conditions in which people live, again, fundamentally important. So many have argued that we need to adopt an upstream way of working if we're going to really have a pro-equity impact on our outcomes. That means advocacy, policy advocacy has to be absolutely central. And linked to that is this increasing emphasis on the need for meaningful community engagement with civil society organization and community groups, which I'll talk about in a minute. And again, to be truly multidisciplinary in our working beyond the health sector into the whole range of sectors that impact upon our outcomes. So inequalities interventions and policies really need to look at the value of regulation, legislation to create these healthier environments that are sustainable, that are co-produced with our community groups, civil society organizations. We need to look at power imbalances and economic inequalities and lever options where we can to create more equitable and fairer societies in the broadest sense, and then health outcomes will also benefit. Now, many of you may have heard of Michael Marmot, who is 2 doors down from me in this corridor, and not that he's here very often at the moment, but his concept of proportionate universalism, that to reduce the social gradient in health and oral health, we need to implement interventions in a proportionate fashion based upon levels of need, that the populations with the highest level of need need the greatest level of intervention input. Now, again, a very old concept, but one we need to keep on coming back to, is the importance of implementing a range of downstream, midstream, and upstream interventions in collaboration and in a complementary manner is fundamentally important. So downstream interventions, evidence-based prevention delivered to people with levels of need, important. It needs to be delivered with appropriate teams, appropriate training, etc. We need midstream interventions around creating healthy environments, healthy settings, such as preschool, schools, care homes, the workplaces, etc. And we've got some good examples of those in different parts of the world. And then lastly, we need a range of upstream interventions, regulation, legislation, fiscal measures. So a good example that Leandra's mentioned is taxation of sugar-sweetened beverages. Over 100 countries around the world now are implementing such policies. This infographic is from Public Health England that Jenny Godson produced a few years ago before she retired. And I just think it nicely highlights that sort of settings approach where across our community, there are many different environments where we can intervene to create health promoting settings that benefit our populations, especially our populations with higher levels of need. Over to Leandra to give some examples of recommendations for Italy. Maybe Leandra, you give a few of those, not all of them maybe.
Yeah, for sure. I will be quick. So, after given the findings about Italy, this one could be some of the key recommendation to reshape and improve the Italy oral healthcare system. And so, some of the recommendation could be like starting from modernizing policies and data collection, because in Italy, the last guidelines were presented years ago, so there is a need to update the oral health guidelines to reflect the recent evidence and advances, and mostly to conduct periodic national epidemiological surveys, obviously to assess the trends and the impact of the intervention and to support the data-driven policy making. Also, we need to, in Italy, there is a need to strengthen the governance. So, for example, to reactivate the technical committee to ensure the regular updating of oral health policies and to promote, for example, regional equity in service provision. There is a need to update and expanding the essential level of assistance for universal basic oral health services. So there is a need to include a minimum package of essential dental services within this level of assistance, ensuring universal access to preventive visit, oral hygiene, emergency treatment, and others. And there is a need to implement this uniformly across all regions. Also, one of the most important things is that there is a need to secure dedicated funding for oral health, and so to introduce a legislative obligation to allocate a specific portion of the National Health Fund to oral health to ensure financial sustainability of expanded service, and also to establish a transparent monitoring system to evaluate effective use of funds at the regional level. Also, there is a big need to enhance financial accessibility, and so to expand the coverage of public oral health service, to introduce dental care subsidies for vulnerable population, and, for example, to promote affordable private insurance model to reduce the financial burden of households. Also, there is a huge need to leverage public-private partnership that I can say that is in Italy are almost absent. You can move to the next slide, please, Richard. So also other kind of recommendation could be that we need to ensure regional harmonization and uniform the service delivery. So strengthen the obligation for all regions to fully implement the oral health service included in the essential level of assistance. There is a big need to simplifying access to care for vulnerable populations. So to establish a centralized system for vulnerable population supported by a national network of dedicated public facilities. Also, there is a big need to invest in prevention and public health initiative, because in Italy, I can say that are almost absent. So there is a need to implement mandatory school-based oral health programs to promote nationwide oral health education campaigns in workplace and community that mostly to introduce fiscal policy, such could be the sugar tax, to reduce the consumption of unhealthy product. Also, again, to address the regional disparities, so to allocate additional funding to underserved areas to increase public dental service availability, and also there is a need to ensure equitable access to care regardless of geographic location. Moreover, there is a big need to enhance monitoring and accountability, because in Italy, there is a need to develop performance indicator and evaluation framework to assess the effectiveness of oral health policies and intervention, and to ensure also systematic data collection and regular reporting to facilitate improvements and maximize the impact of public investment in oral health. So, to conclude about Italy, addressing these inequities in oral health care is not merely a financial issue, but it's more a moral imperative aligned with the Italian constitutional guarantee of health as a fundamental human right. It is crucial so to rethink and restructure Italy's approach to oral health to ensure equitable and fair access for all individuals in Italy. Thank you.
Thank you, Landra. Sorry, my mouse went crazy for a minute, so it jumped ahead. Thank you. So let's just very quickly finish off because we're running out of time, and then we want to have some discussion because it'd be good to hear, because we've got lots of people on the call. So just very finally, what I want to do is just give a brief overview of a new program that groups of us are working on that begins to take some of this agenda forward in a research agenda. So this is a global health group, oral health group, that's funded by the UK National Institutes of Health Research. It's a collaboration across UK institutions, including UCL, Queen Mary, University of Glasgow, University of Staffordshire. And what we're doing as an overall program is working in 4 middle-income countries: Colombia, Brazil, Kenya, and India. And this program, this is an image of a few of us when we met in London a couple of months ago. And essentially, this program has 3 work packages of research, one of which is looking at oral health inequalities, one of which is looking at commercial determinants of oral health, and the third work package is looking at systems reform and innovation. And then under each of these work packages, there are sub-studies that are now underway in different ways. Now, there's not time to go into a lot of detail of this, but as you can see, we have a work package on inequalities, and the sort of most exciting bit is that this program is enabling us to work with the communities across these 4 countries to co-develop and co-design interventions that are pro-equity in focus. So what we have as a substantial part of this overall program is funding to enable us to undertake community engagement and involvement with marginalized and disadvantaged communities in these 4 countries. And without going into all the details, what we basically have is a range of processes that we're now undertaking to understand the communities through mapping and data collection, creating community forums and citizen juries, developing community engagement action plans in each country, and then implement, that we've now started, a whole range of outreach activities, engaging with communities, employing community link workers, and developing insights through all of this work to inform the development and evaluation of interventions. And just very quickly, as images, in each country, different communities are being discussed with, talked to, listened to, brought on side with different innovative arts, visual arts, whole range of different things to really try and get people to provide what they think the solutions are locally for oral health, so policy development in relation to oral health inequalities. So it's genuinely a sort of interesting, innovative process. And what we're leading this to is to conduct 2 feasibility studies in each country to develop interventions, test their feasibility, to then inform a future application to do a full-scale evaluation of these interventions. So just to finish off, we're 5 minutes over. What Leandra and we have tried to do in the last 45 minutes is highlight the relevance and importance of addressing oral health inequalities, stressing the need to frame oral health as a basic and fundamental human right, recognizing, whether it's in Italy, whether it's in the UK, other parts of Europe, we need to recognize the limitations of current preventive approaches, particularly in terms of achieving pro-equity and reduction in health inequalities. We've looked at some policy options and examples and highlighted the importance of this community engagement, meaningful community engagement, leading to co-production, co-design of interventions to see where that takes us. So thank you very much for your time. This is just a quote from John McKinley. I interviewed him last year. He's the originator of the upstream concept back in the 1970s. And just to quote him, we've got to fight fire with fire. And I think that's a sort of rallying call for us all. So thank you all very much. And shall I stop sharing some? 1 minute. Oops. And we can now sort of take questions. So apologies for...
Just wanted to say a huge thank you to Leandro and Richard for a thought-provoking presentation. And we would be happy to take any questions. So the floor is yours, everybody. If you just put your hand up and ask the question.
I can see David Conway's got a hand up.
David, yeah.
Fantastic, Leandro and Richard. Really enjoyed that. Two very brief points, if I may. One about the education intervention in Edinburgh. We quote that all along, and it does widen inequalities, as you say, but not to be confused with action-orientated school-based interventions like the one launched in England last week of supervised daily toothbrushing. So we do that in Child Smile, and it can improve oral health in the most deprived communities and across the population without necessarily widening inequalities. But it didn't, and our experience in Scotland is it doesn't reduce the gradient, and for that you do need the upstream structural changes that you're proposing. And if I may, as a kind of question for you, I totally agree with the social, the economic, and the commercial determinants driving that. And I think we are a little bit woollier in our language around policy advocacy. But there was an editorial in Nature today from the US saying that public health experts need to get more, not less, political. And there's something about being really politically active in this space that I think maybe that's what you mean by radical advocacy. But I think that's a really important space. Thanks.
Thanks, David. That's a really good point. And I think the Edinburgh, that 1980s Edinburgh intervention was a classic health education intervention. So it wasn't interactive program that you're describing now that's being implemented. It was a passive health education program. And I have to say, I started my career, that's exactly what I did. Now, all of you are far too young, but there was a program called Natural Nashers. And I used to go into schools, do this educational thing, and I strongly believed I was doing the right thing. But the evidence is it probably had minimal effect amongst the populations that needed it the most. But you're right to differentiate that from the sort of more current approaches. In relation to the sort of radical political advocacy, it's ironic that a paper published in Nature should be saying that from the US with the sort of current agenda, but I think it's absolutely right. And I think what I've learned in the last few years is with the commercial determinants is how these companies are targeting more vulnerable populations in their marketing, social marketing, policy influence, etc. So that, I think, is something that needs to be called out and exposed. And that is an important thing that I've certainly learned in the last few years about those tactics. So very good point. Thank you.
I think we had Dr. Tasnima who wanted to come in. Did you have a question? Please go ahead.
I wanted to thank the professors for the interesting topic and for raising awareness about such a human discussion. We really do need more doctors like this in the world. So thank you so much for being so aware about people in need and everything. So thank you so much.
Thank you.
I've got a quick question, Richard. We talk about the social determinants and commercial determinants. A lot of our undergraduate and postgraduate students believe that health services are our savior and they will contribute to oral health improvements. According to the evidence, what's the contribution of dental services to our general oral health and well-being, I suppose?
Good question. And I think, again, maybe it's just a sign of getting old. I think, we don't want to blame dentists for not making a contribution, because dental services are incredibly important for people in pain, for people that need support, for people that need treatment. So I think dental services are immensely important. I suppose what we probably haven't got, and I don't think we've got an answer to that question, Huda, in terms of what proportion of health improvement or reduction in health inequalities can dental services alone provide. But they have to be part of the solution. And that means we have to engage with our clinical colleagues who are working in the coalface. That is an important element. And I think in some fields of sexual health, mental health, issues of developing equity toolkits for clinical settings, I think that's an interesting area that I'm keen to explore more as we move forward with our projects. So I think let's not blame health services for things. We need to improve how they can become more engaged in health improvement and equity agendas. And I think that's our role as public health people. That's how I see what we should do. But of course, we also need outside of the health system. So it's not one or the other, it's both. So I would be positive and say, look, we need our clinical colleagues and others to help us. I can see Astromenas has got his hand up.
Okay, thank you very much, Richard. Thank you both for your incredible presentation. A lot of comments, a lot of thoughts, but I will stay in one question. I would like to ask you about your experience in the UCL Center for Oral Health Inequalities. I think that a center like this could be very helpful for countries like Greece, for example, or Italy, or other countries who have high inequalities, low public dental expenditure, a lot of problems. And we have suggested to create a center for inequalities and policies monitoring. It has been accepted in the first stage, but not yet funded. So I would like to provide us one, two arguments for advocacy for this plan, if you think that it would be very helpful. Thanks again. Thank you.
Well, Astromenas, I think to respond to that, I think all of us on this call are interested in the topic. Otherwise, why are we spending an hour of our busy lives here? But I think what we haven't done very well is worked very well effectively with academia, with health services, with policy people, and very importantly, with community civil society groups, our biggest gap of all. But, David, Conway, Ivor, lots of people on the call, we need to work together in a much more effective, seamless way. We've been talking about this for 40, 50 years. It now is time for action. And again, I don't want to be too political, but at European level, we can do so much if we do work together and learn from each other. And, you were at that Bangkok meeting. The workshop that WHO organized for European region was incredibly positive. And there were countries from all across Europe sharing their problems, and we agreed to work together. Now, we need to go back to WHO and say, look, let's move that forward. But, I really am optimistic that we can learn and share good examples. Lots of interesting things happening in Scotland, Wales, Israel, other countries. Let's share and collaborate, and the agenda's moving forward, I think.
Thank you.
I can predict a difficult question coming from Ali.
Hi. Well, thank you very much for the presentation. It was very informative, both of you. Richard, I don't want to blame the oral health services. However, as you showed yourself, the inequality that you saw 40 years ago still exists there. And the big money that comes to oral health is the money that NHS pays to level 1 dental services. And clearly this 2006 contract between NHS and dental practices has not solved anything. So do you think it's a time that the dental public health community puts forward and proposes a new contract that solves a little bit of the problem, especially that now we have an inside man there.
I'm not sure we have an inside man, but
Inside woman.
oh, inside women. Okay. No, I think, of course, in any country in Europe, we need a system of remuneration and payment that is about promoting health, that has an equity focus. Now, in all the countries in Europe, I don't know which one is best for that, but I have somebody in our International Department of Health office wants me to reach out to different European countries and look at some good practice. So things are moving forward, but of course, the system in the UK, in England, does not work. It's not set up to improve health. It's definitely not set up to reduce inequalities. So of course, you're absolutely right, Ali. It definitely needs changing. Now, I don't know if Rebecca Harris is on the call or not, but there are people working in that space. It's urgently needed. It's long overdue. And we need to again look, and there's no magic system that's going to be perfect, but the system in England certainly not working. We need to look at better systems to make them more health promoting, more equity focused, and that's to me the biggest challenge. And I haven't got the answer to it, but I think we need definite change.
Thank you.
I have a question, please.
Please go ahead.
Thank you. So my name is Hannah Arab. Thank you very much for this informative webinar. So how can medical dental public health graduates contribute to improving dental care access and addressing dental health inequalities in deprived urban and rural areas in Scotland, for example?
Well, maybe we should ask David Conroy to answer that. It's a difficult question, but I can see in the call we've got people like Rob Whitten, we've got a whole range of people. So there's a range of initiatives that I suppose are moving and engaging with disadvantaged communities. And we need to make our services more open and acceptable to different population groups. I think the problem often is we've created dental services for people like us, professional people. We need to look at different models of creating those and outreach services that are more flexible. There are different models, and then people on this line are much more experienced than me of working and evaluating more responsive, more open, more amenable services rather than the rigid model that often we expect people to fit into. So it hasn't really answered your question fully, but I don't know if Rob or David or others want to come in, but I can see Joe Dawson and then Maria. Maybe we stop, otherwise it's going to be too late.
Joe, please go ahead.
Hello, sorry, I was on mute. Sorry. Hi, and thank you so much. I was delighted to see your presentation. Thank you. Some of it I'd seen before, some of it very new and interesting. I'm a dental nurse working in Cambridgeshire. I work part-time in general practice, so I'm in the clinical problem area that you mentioned. But also I run a social enterprise to run oral health promotion projects in primary schools. And so what I'm interested in asking you about, particularly that you're up the corridor from Michael Marmot, wow, I bow to the god of all of his social, his books are amazing. And I totally get where everything is so well researched, but how do I access research and funding and even just connections to test out what we're doing and to prove the effectiveness of it?
Well, Joe, that's a very good question. And I have to say, one of the things I feel most depressed about, and I'm actually very positive generally, and I think things are moving forward. But one thing that in in particular in the UK, we had very good networks of people working health promotion that linked together, that we talked about evaluation, there were different professional groups. A lot of that has disappeared because unfortunately the system hasn't given support to them. And I think people like you working need, I mean, there are still some national organizations, and I'm sure you're part of those, but many years ago we had a oral health promotion research group that linked academics with practitioners, and behind me with evaluation guides, all this stuff. Now all that's out of date now. It's all 30 years plus out of date, but that need to have closer collaboration between researchers and practitioners and public health people is even more important than ever. And I'm not answering your question, Joe, unfortunately, but I think you can't do it in isolation. You really can't. How can you be an expert in dental nursing and evaluation and school-based interventions? You need to link together with others in the field. And I think that's a problem across Europe, coming back to Astromenis's point, of we need those better networks again. And to share experience, etc. So I haven't really answered your question, unfortunately, but keep going and try and link together, maybe with other people working in school health more generally, not oral health, but people working in obesity, other areas of public health. That might be a way ahead for you.
Okay, thanks ever so much. Thanks, Richard.
Maria.
Hello. Hello, everybody. Professor, thank you for the presentation and, of course, all your collaborators. And I totally agree with the broader picture that we need more upstream politics to tackle the health inequalities. But I wonder what is the reason for, on your opinion, that people from deprived areas don't benefit from educational, oral health educational interventions? Is it because they don't have the educational background to absorb, to understand the information? Or is it because they are, let's say, disappointed from the system, from the state, and they don't trust state interventions?
Well, Maria, it's a very good question. And I think you've answered your own question. It's a whole combination of factors, isn't it? It's because the opportunity to change may not exist for them if they're in an economically stretched position, they don't have the capacity to purchase healthier foods, etc., etc. They may not trust scientific evidence anymore. The misinformation, disinformation that's been peddled by certain groups undermines credibility. So people don't trust others that give advice. And again, I just had a meeting earlier on from people in South America. In some countries, the lack of trust in government is very high. And that's a broader issue. We didn't create those conditions. So I think, as always, there's a whole range of reasons why people from socioeconomically disadvantaged backgrounds are not able to make healthier choices. It's a combination of lack of opportunity, lack of resource, distrust, etc. So it means we have to be conscious of those factors, and some of them we can't change, but we have to acknowledge them. So thank you for the question.
Dr. Tasnima, I think you have another question. Your hand seems to be up.
Yes, I do. So we already talked about how clinicians can contribute to this project and to the whole thing. So I was wondering if there is a place for international students like myself to help out with this project or this whole subject. I think an international young student would be quite an interesting diversity in the whole subject. Thank you.
Well, that's a very good point. And just as one example, our NIHR program does have a capacity building and training element. And so we've got resources to support people from each of those countries to do a master's degree, for example, only a small number, but we've also developing a range of online training resources. Now, in India and in Brazil and Colombia and Kenya, those resources are being developed. So maybe if you look on our website on the core program, there are online courses that we're offering and developing to try and help people that are interested in the space. Now, we can't do it all, of course, but no, it's a very important point, particularly for students, to link together with different initiatives. So very good point.
Can I just add to that? So the European Association for Dental Public Health is obviously holding a series of masterclasses as part of capacity building, but also we are due to launch a mentorship program for early career researchers and for students. And that's been led by Dr. Nicolas Girardot, and that's going to be launched at the annual general meeting in Rome to support students and early careers researchers. Thank you. Any other questions?
Just to flag, there's a question in the chat from Hadi, if they would like to unmute and ask the question. If not, I can say it. So they've asked what kind of evidences may help in the struggle when they're persuading governors, because that can be very difficult.
So I'm trying to understand. Yeah, so I think maybe that's where we need to develop our skills of sort of advocacy. And I think linked to that, it depends on the sort of political system, et cetera, but I really strongly believe if we are more effective with community engagement and involvement and work with civil society groups, they are a very powerful force that can influence politicians and governance processes. Often politicians won't listen to us, but they might well listen to empowered communities that are demanding improvements in different elements. So I think that's where that combined community engagement approach potentially has opportunity for something very more meaningful.
And there's one more question in the chat. Michael, are you there to ask this? Because it's quite a long question. I don't know if Michael's still on the call.
Michael's gone home for dinner.
Okay, okay. It seems to be around spending smarter in relation to governments and societies because of their finances for how they could fund more proposed services, for example, in Italy. Again, it might be to do with the evidence, with the argument that we've just talked about, to be honest.
I suppose that's return on investment as well, isn't it? About investing in certain interventions, what economic benefits are coming from it. Now, again, we've begun to do some more work on that, haven't we, collectively as a group. And I think we have to prioritize spending. If we're going to have to spend more on defense, if we're going to spend money on health, we have to do it wisely. So that arguments, and I'm the last person to advise on economic arguments, but the need for refined evidence on economic benefits from interventions is fundamentally important. So people like Stefan Listel and many others are working in that space. The evidence is coming together, but of course we need more.
I think that's the end of the questions. Danielle, is that right? Richard is nodding. I think.
Yes, I think so from the chat, from what I've seen.
So just want to say a huge thank you to Leandro and Richard again for a very thought-provoking presentation. Thank you for your time. We are very grateful on behalf of EADPH. Thanks very much.
Thank you all. Good evening, everyone.
Have a nice evening. Bye-bye.
Bye-bye.
Bye.